The extraction of 3010 can be a little bit tricky because it's placed caudal in the mouth and there's not a lot of room. But here I can show you what I do. So I start with stab incisions, releasing the gingiva off of the tooth. And you want to extend your release, including the tooth in front and behind of the tooth that you are extracting. The next part is the lingual side. This can be a little bit tricky. Here's where the flap tends to tear. How you avoid it is you take your scalpel blade and follow the curvature of the tooth and make a deep stab incision in these two exact positions. They will release the interdental papilla. And after I've released my flap, you can see that the incision is extending a little bit into the tooth in front. And you can go up to the furcation area if you want, but not further. Here's another view. So you can see the flap has been released a little bit off of the tooth in front and in back also. Up to the furcation that's allowed, up to the furcation of the healthy tooth that you don't want to extract. And here is how I do it. So I take my periostal elevator and I start here and I do a twisting motion to release the gingiva off of the bone and do a combination of twisting and pushing. And it's smart to move sideways instead of just pushing apical, so pushing down into the tissue. It's a more risky business to push down, so you want to get down a little bit and then move sideways like I'm doing right here. And this is about the amount of exposure that you need to extract this tooth. So before getting into it, I just want to show you where I position my hands. And you can see on my right hand how I keep the burr or the handpiece, and I'm resting my fingers on the dog. And the left hand is also resting on the dog while keeping the gums away. And this is to be very safe, so you don't want the handpiece to be balancing in the air. You want the hand to be resting on the dog, and then tiny little movements with your fingers, index finger and thumb, moving the head from side to side. So it's just my fingers doing this movement. So you want to remove the alveolar bone, and you can go down to about 70-80% of the root's length. That's what I usually do. You can go less if you want, you can go a little bit more if you want. Just be aware, in small breed dogs, the nerve and vessel often are situated buccal. So you may run into them while drilling. So you don't want to go too deep. So I just needed a better grip here. Get the flap, move out of the way, and then I'm start drilling. So I'm using this cross-cut tapered Fisher burr. It's called a 701L surgical length. It's a little bit longer than normal burrs. And you want to just paint away the bone that's overlying the root. And you see some ligament remnants here, the white stuff. You need to drill that away too. And I like to drill that stuff away in the furcation like I'm doing here, so I can get a nice view of where that bone tooth interface is. And now I'm asking for a tongue retractor, simply because when I'm drilling through the tooth, I don't want to inadvertently hit my tongue, the tongue with my drill. That's why I'm using this wooden tongue depressor as a safety measure. So just a little bit of suctioning. And now we're ready to luxate. And I always start with this horizontal elevation, so go in between the roots and just try and twist a little bit just to see how mobile they are. And then you should move around 360 degrees around each tooth root, and you want to get some purchase, push your luxator in between the bone and the tooth and make a gentle twist. And having very sharp luxators really increases your speed, because you can with ease, like here, push it between the tooth and the bone. And on the lingual part, you need a very sharp luxator to get between the bone and the tooth to avoid slipping, because the bone is very thin in this area. So I just keep going, luxating gently, and you can see it starts to bleed, and that's a good sign, because now you know that you are severing the fibers, the sharpish fibers of the periodontal ligament. They are getting torn, and that's why it starts to bleed. And the bleeding itself will put some pressure in the alveolus, helping you getting this root out. So I felt quite comfortable that this root now is loose enough so I can start to apply my forceps and a gentle twisting and pulling motion. And this is a large breed dog, so the roots are not extremely thin, not extremely curved. So I'm allowed to do a little bit of twisting in this case. Whoops, and there it is. And a little bit more luxation of the mesial root. And now once that distal root is gone, you can sometimes go in the furcation area and do a little bit of release there. This is the worst root to break, the mesial root, because it's easier to get the distal root out if it's broken than the mesial root, I think, because the tooth in front is a little bit in the way. So you want to have a little bit of patience getting out this root, and just a finger-light rotation of your luxator, and keep it there for 5 to 10 seconds, and that will release the fibers. And there you go. The mesial root is out, a slight curve, but it's intact. And you always want to do a post-op x-ray to make sure that you got everything, and make sure that's nothing in the alveolus. Could be bone, pieces of bone, could be calculus, all kinds of stuff. So you want to scrape the alveolus out with a curette or a sharp spoon, and just to make sure any of the granulation tissue and sitting in there is out, and that will increase the speed of healing, and it will also facilitate a nice blood clot that you want in there when you close the defect. So always, if it's not filled with blood, you should scrape the sides to make it bleed a little bit before you close. And an important thing to remember is to clean the distal root of the tooth in front of it. And here I'm using a curette. It's a curette, it's called 1314. It's Gracie curette, so it's kind of curved here, and it's easy to get in and clean the distal part of the root. Now I'm placing my sutures, and I'm using a 4-0 monochrome. It's purple dyed, on a reverse cutting needle. And I usually do a surgeon's knot with a couple of extra throws, so I'll do the double throw and then 3 extra on top of that. And you want to get nice big bites, at least 3 millimeters on each side. In this case, it was not really necessary to do a lot of releasing because of the gingival release I did in the beginning. It was quite loose, so I could close without any tension. And you don't want any tension because then it's going to dehiss. Alright, so I hope this video helped you in extracting this tooth in the future.